Good afternoon and welcome once again to the Independent Sage briefing, everyone. This week, excess death figures hit a new 2-year high, and this is continuing to put intense pressure on the NHS. Now, some of the best people to analyse what national death figures mean are actually insurance specialists called actuaries, because life insurance calculations depend upon knowing about life expectancy and risks of death. So today we have a very special guest, Stuart McDonald, one of the top actuaries in the country, and also deputy chair of the continuous mortality investigation that specialises in understanding why we've got this problem. And he'll be talking us through trends and explain what we could attribute these excess death numbers to. And we've also got some really fascinating questions from you, the public, so stick around for that. But before we get to any of this, we have our latest numbers. For that, we have Dr. Duncan Robertson, our Duke of Hazard, and he will give us a picture of the latest COVID numbers and trends, and then he'll go on to introduce and lead the discussion with Stuart McDonald. So over to you, Duncan.
Thank you very much, Anthony. So this week is relatively positive in terms of COVID data. So we're seeing that infections are falling in all parts of the UK. We're getting flu and COVID admissions are both declining as well. But we are still seeing high levels of beds that are occupied by patients, particularly those with long stays. And then we're going to sort of look into vaccination, particularly by demographic, in terms of what sort of people are getting most vaccinated and when. And then I think we're starting, certainly by date of death, we're seeing deaths potentially falling, but as I'm sure we'll come on to, there remains excess mortality. So infections, so this is once again from the ONS coronavirus infection survey. So we can still see that we had this peak earlier in the year, and we're certainly very much over that peak. So the declines are basically in every UK country, England, Wales, Northern Ireland and Scotland. And of course, with this data, we are looking back. So this is a couple of weeks old, but it's the latest data we have. So good news. But of course, that does split by country. And we're seeing that, Northern Ireland is slightly higher in terms of prevalence at that time, but certainly those rates are falling in all countries. And this is over time, so you can see the orange bars are the latest figures, and they are, as you can see, falling from that peak. So we're seeing the ends of the peaks in all those countries. So this is good news. In terms of where the rates are, they're highest in over 70s, and there seems, a fairly steady gradient, not quite constant, but certainly the highest in the over 70s and lowest in school children. And this is particularly looking at school children. The orange bars are school holidays, and the only area where prevalence may not be coming down, we're still not sure, is age 2 to school year 6. So we're still in all other age groups, we're seeing these falls. So as I say, good news. Hospital admissions, we're also seeing falls in hospital admissions, as we would perhaps expect. And this is two lines here. We've got the COVID-19 admission rate in red and also the influenza admission rate. So we can see that we're having these admissions, wave after wave after wave of COVID admissions. The latest wave is coming down, but we've only really had one major flu admission rate into hospital, and that too is coming down. So you can see that kind of intense pressure over the Christmas and New Year period is hopefully starting to subside. And this is looking at the admission rates for flu. And as you can see that we had this, particularly high peak. The dashed lines are pre-COVID years, and you can't really make them out, but the sort of the brown and the orange lines there are the admission rates for 2021, when there was really no flu season to talk of, and 21 to 22. So you can see we're back to having a flu season, but the flu season we did have is significantly higher this year. And then we're looking at the admissions for COVID compared to a peak in 2019 flu admissions. And as you can see, we're having kind of these relatively high levels of admissions, certainly not as high as we did in the peak of the entire pandemic, but it sort of definitely hasn't gone away in terms of admissions that happen, certainly compared to flu as well. So in terms of hospital beds, these are people who are obviously in hospital. This is looking at critical care beds in England and comparing them to the last few years. 22 to 23 is that line in red. You can see 20 to 21, the orange line was, huge amounts of people going into COVID admissions, but we are still, higher than I think we'd like to be in terms of beds occupied across England. And this is looking at this flu patients. So even though the flu wave is declining, there are still patients in hospital with flu. So this, of course, is pressure on the health system. And this is looking at people who have stayed in hospital for more than 7 days. And we can see that this is significantly higher than previous years, certainly the previous 5 years, which of course is a bit of a worry in terms of people actually getting out of hospital. So this is people who've stayed longer than 7 days, there's people who stayed longer than 14 days, and people who stayed more than 21 days. So there are, a number of people who stayed in hospital for a long time, and that is higher than it has been in the previous few years. So in terms of vaccinations, we are, of course, coming to, the end of this, the current regime for vaccinations, and we'll talk about the JCVI changes that have come up. But this is looking at the recency of people who have been vaccinated. So there are a significant number of people who are still unvaccinated, and actually quite a few of those will be children, and we'll see that quite a few of them won't. But you can see over time, we've had this autumn and winter vaccination push, the booster push, and then as that has gone into the past, we are seeing the length of time that people have had since their last vaccination increasing. And in terms of who has the most time since vaccination, well, you can see really it is very much concentrating on older people, and younger people certainly either haven't had any vaccinations in terms of younger children, but certainly the over 80s are the most recently vaccinated, which is good news because, of course, all other things considered, they would be the most vulnerable. And then we can split that down by ethnicity, and you can see actually, something that's been true for the last quite a bit of the pandemic is there are differences between the vaccination rates of people depending on ethnicity, which is, of course, a bit of an issue. And that brings us on to the JCVI change. So the JCVI have mentioned what they're going to do going through for 2023, particularly the autumn 2023 booster campaign. There is also going to be a spring 2023 campaign for the most clinically vulnerable, the most vulnerable, sorry. So this is changes going forward. And just on the data of the vaccination programme, this is from the vaccination report from UK HSA. We can see actually that there is protection covered by the vaccines compared to those who have had a previous vaccine, but their immunity has waned. So deaths, of course, this is the subject of this this week, really. But so we can look at the statistics on deaths. This is looking by date of death, and we can see there are, this is daily deaths. Looking at when people died rather than when that data was reported, and hopefully we're seeing a downturn in those. This is looking at the May 2021 until January 2023. So those last data is incomplete, but hopefully there's a downward trend, and then this applies to all UK countries. And also the statistic we have, which isn't as reliable, but is more recent, is deaths within 28 days of a positive test, and that seems to be coming down as well. So as I say, that's not quite as reliable, but that we'll come into some of these sources of data when we later on. And then excess mortality. And of course, this is going to be a focus of today, but just generally, just to introduce, there are, we can look at excess mortality as in terms of numbers across the whole country, but I think, look, there are differences in deprivation. You can see over the course of the pandemic, we have had excess mortality, which has been most concentrated in the most deprived areas. And what I think is interesting is how that's changed over time. So certainly in the first year, 2020, very much focused in the most deprived areas, same in 2021. We're seeing a bit of a shift now in terms of it's a bit more equally distributed, but even the least deprived areas perhaps have higher excess mortality, but we can go into that in detail. And then this is looking at the number of deaths with COVID on the death certificate, similar sort of story over the period of the pandemic, in that the most deprived areas tended to have higher rates. Fire alarm there. And we can see this happens, a similar sort of story as excess mortality, but excess deaths on the death certificate. It's very much concentrated in lower, more deprived areas in 2020 and 2021, more evenly distributed in 2022. And this is looking at, the comparison to where we'd, where if you put a baseline before COVID, then you perhaps see that it is excess, but we'll certainly come into that later on. And then looking once again at, you can split this down by ethnicity as well. So this is the Office for Health Improvement and Disparities. They have a excess mortality dashboard, and certainly this data is from there. And then by age, you can see, once again, it's quite interesting to see 2020, very much excess deaths concentrated in terms of elderly people. That's come down as we go into 2022. And I think what's interesting is that 50 to 64 age range perhaps is higher than you would otherwise expect. So there we are. From this week, we have infections falling in all UK nations, flu and COVID admissions into hospital both declining. We have high levels of beds occupied by long-staying patients. We've looked at vaccine demographics, and while deaths do appear to be falling from their current peak, there does appear to be excess mortality. So I think that's perhaps a good time to introduce our guest for today, who's Stuart McDonald, who is, as Anthony said, is prominent within the actuarial profession and is Deputy Chair of the Continuous Mortality Investigation. Early in 2020, around the same time as Independence Age started, he founded and chairs the COVID-19 Actuaries Response Group. And Stuart was awarded an MBE for Stuart services to public health in the 2022 New Year's Honours. So welcome, Stuart. So Professor Christina, Pagel and I are going to chair this part of the session. But I think before we begin, I think, it's worth pointing out that we're going to be talking about deaths, and, deaths are an emotive issue and, of course, have affected us in different ways. And I think, even though we are going to be talking about statistics, it's worth pointing out that behind those statistics are real stories and real people. So I think with that, I think it would be good to sort of just ask Stuart, what do actuaries do? Because I think a lot of us have perhaps seen other professions, epidemiologists, for example. We may have an understanding of what they do, but I don't think we really have much of an understanding of what actuaries do. So what do they do?
Yeah, so actuaries are involved in a variety of different disciplines, essentially where there is risk and uncertainty, and particularly where there is a necessity to kind of balance events which are occurring over different times. So a good example would be the sphere of pensions, where it's important to know how much money is required today to pay an income for life. There's all sorts of areas of uncertainty there. How long are people going to live? What are asset returns going to be? Interest rates, inflation, and so on. So actuaries are able to quantify these different measures of risk and project out into the future using a variety of statistical approaches. we're a profession, and with a royal charter, and take our public interest objectives very, very seriously. So that kind of professional obligation will often trump commercial considerations. So many actuaries work in the private sector, advising insurance companies, advising pension funds, and so on, as you would expect.
Fantastic. That's great. And I think you've got a few slides about talking about how actuaries look at deaths and excess deaths. So maybe we could perhaps have those up, and feel free to sort of do the next slide, please thing. So I suppose the question is it just in terms of counting deaths, or is it more sophisticated?
Yeah, so I think what I'll do is maybe take the audience on a bit of a journey from counting deaths, so that we can start with those more basic concepts, and then move on to the sort of age standardized mortality rate approach, so that we can get more of a introduce complexity as we go, hopefully at a sort of manageable pace. So if we could move to the next slide, let's start with the historic pattern of death counts in England and Wales. So you can see here that actually it's relatively flat, with over 500,000 deaths occurring in England and Wales each year. Death counts were falling until around 2010, 2011, and then started rising. It's important to be aware that there are really different effects going on here. Although that looks fairly flat from year to year, there's a lot going on below the surface. So actually, I'll go to the next slide, and that will illustrate that a bit more clearly. But essentially, you've got two different trends which are, to some extent, broadly offsetting each other. So you've got an aging population and a growing population, but it's actually the aging of the population that has a much more significant effect in driving up the number of deaths that we'd expect from one year to the next. So the chart on the left here is a population pyramid from the ONS. The borders on that chart are showing you what the population looked like in 2008, and then the grey bars are showing you what it will look like in 2028. So we're sort of 3/4 of the way through that transition. And really what you can see is our population is getting older. There's far more people in the oldest age groups, and far fewer in the younger age groups, which will come up and ultimately financially support those, but that's another lecture.
So Stuart, just on that. So on that slide on the left, you've got a population pyramid. So does that mean that effectively the people are sort of going up that age range as they get older? Is that essentially what happens? And some of them will die, and so you would expect it to sort of get smaller over time, so it kind of moves up. Is that right?
Yeah, we call them population pyramids by historic convention, because they used to be pyramid shaped, much wider at the bottom. Obviously, that's not the reality that we're in. They're more like population sausages now, aren't they? But yeah, as time goes on, with each passing year, a cohort moves up and ages by a year. Obviously, some of them die. There's some migration, but you can see how the population evolves over time with these sorts of illustrations, and that one is from the ONS. On the right, it's a slightly old.
Can I just say, so basically what you're saying is that bulge in the Middle Ages is now going into the old ages, and it's not being replaced. So that's why there's that gap.
Yes, exactly. Yeah, you can see the gap where the current, or the generation of people in their sort of 40s and 50s in 2028 will be a lot smaller than it was back in 2028. The baby boomers are into the retirement ages now, and will be moving up through those ages. And that just means that we expect the number of deaths to go up each year from this point. So if death rates remained completely unchanged, and we're going to talk a lot about death rates, but if death rates stayed completely flat, you would still see an increasing number of deaths year by year as the population grows, but more importantly, as the population ages. So I talked about offsetting trends. On the right is the other great trend, which is falling death rates. So I've just highlighted, or Public Health England have highlighted before they became UKHSA, some of the most dramatic falls in causes of death. So you can see the really great gains over the last couple of decades were cardiovascular causes. So you can see there heart disease and strokes. We've made progress, great strides in all sorts of different causes of death. So a lot of reduction in deaths from flu and pneumonia, and lung cancer, of course, as fewer and fewer people smoke. But it's these cardio deaths and the reduction in those death rates that have driven a lot of the historic improvement in mortality. So as I said, two different trends going on. They sort of offset each other. If we go to the next slide, I've just repeated the slide from before with the counts, but I've also then overlaid what we're going to call ASMR. So you'll see this abbreviation a lot as we go through the slide. So age standardized mortality rate. What we're doing there is we're taking all the different mortality rates that apply at different ages, and mortality varies very, very dramatically with age, as you can imagine. Mortality rates for people in their 80s and 90s, thousands of times higher than mortality rates that young adults would experience. And what we're doing is essentially taking a standard population. It's called the European Standard Population. And we're saying if the population structure stayed exactly like that, what would mortality rates be? So that we don't get confused about the fact that the population is aging. Hopefully that's clear. And you can see that these age standardized mortality rates have been falling. And there's actually two trends here. Sorry, Christina, do you want to come in?
Yeah, I was just going to say, so basically the ASMR is like the fairest and the fairest way of comparing deaths across different times and different regions.
Yes, I would say so, because you're standardizing the population. So if you were to compare two different countries, you might look at the population of some Eastern European countries, and the average age is much, much younger than the average age in the UK or Italy. And so you'd think, well, the death rates are lower. But they're only lower because people are younger. And so really, really important to work with these age standardized mortality rates. And we've seen this sort of thing going on in the pandemic as well. There was a bit of misinformation floating around a year or two ago that unvaccinated death rates were lower. And that was just because of the unvaccinated people were younger. They were children and teens. And as much as vaccines have an incredible effect in reducing mortality rate, it's not as pronounced as the effect of age. And so if you compare a load of people in their 60s and 70s, you're going to get a much higher mortality rate than when you compare a load of teenagers. So ASMR, absolutely, in my view, the fairest way to look at it. People talk about the CMI, the Continuous Mortality Investigations approach of using ASMRs as being the gold standard. I mean, I would say that I'm a volunteer there, but actually it's the technique that's the gold standard, not the body. It's not controversial. ONS do this stuff too. They just don't do it in their weekly reports. Their weekly reports predate the pandemic. By historic convention, they're just a quick, immediate count of the latest data, and they stick to death counts. When they do their proper analysis, their monthly mortality analysis or their annual, they use ASMR too because it's the right thing to do. So you can see this trend. What's quite interesting is that we'll talk about baselines shortly. So this is what you compare against when you're trying to work out if there's been excess deaths. You can see that the counts has been fairly flat, whereas the ASMR has had this trend downwards, which means it's sort of okay to look at a historic average for your counts, but you can't really do that for ASMR because it's falling constantly. So if you're looking in the rearview mirror, the current year, you would always expect to have lower mortality rates than the historic average. So it's just worth keeping in mind that depending on the technique that you're using to calculate excess deaths, you might need a different baseline. And I've talked about that trend. There's actually two trends in that chart. You can hopefully see sort of pre-2010, things were falling very quickly. And then in the most recent decade before COVID, it fell more slowly. We will move on to what happened during COVID for those that are desperate for the spoilers. Let's do that now. And this is now showing you weekly death counts. So starting with just the number of deaths observed. So we're going to move on to age standardized mortality, but I'll just walk you through the story of the pandemic. You can see how dramatic the first wave was. I want to highlight, because it's important throughout, this is using death registrations data, because that's what becomes available most quickly from the Office for National Statistics. We don't have to wait for the occurrences to be totted up, which is why you get these distortions that arise from bank holidays. You can probably mentally spot where Easter is lying and where the May bank holidays are. Those move a bit, and where Christmas lies. So there is a bit of distortion in this death registrations data. The other thing I want to talk about is the baseline used here. So the baseline I'm showing is the current 5-year average. And this is ONS's current 5-year average, where they're using the last 3 pre-pandemic years, so 2017, 18, and 19. They're ignoring 2020 because of that dramatic spike that you can see. They don't want that to influence the 5-year average, but they are including 2021 and 2022, when there was excess mortality, but it was a bit less peaky, and so it doesn't distort the baseline so much. I wasn't sure about that approach, and I independently kind of took a look at it, and I have actually satisfied myself that it's quite reasonable. By including those 2 most recent pandemic years, it's essentially proxying that demographic change that we talked about earlier. I've done a blog on that, and I can share a link to that in due course. I think it's a bit technical to focus on here, but if you'll take my word for it, I think the baseline they're using is quite reasonable for assessing mortality.
Yeah, so I just want to say, because I know we've spoken about this and people might think it seems really unfair to include 2021, but basically using 2015 to 2019, which is the alternative, is now not fair anymore either, because the population has aged.
Yeah, exactly right.
So this is now as good as using that.
Yeah, if you were to use 2015 to 19, you're looking back. The average point there is 2017. That's now 6 years ago. You're ignoring 6 years of demographic change there. And that would lead to an overstatement of the excess. By including those most recent pandemic years, as you say, 2021's the problem because of the spike. I'll show it on the next slide if we can. So I think we've skipped forward. We're skipping forward quite a lot. If we can come back to the 2021 slide, that's it, and forward again. That's it. So you can see the second wave, so that does distort things at the start of the year. But as time goes on, the approach, the excess deaths calculated for 2021 will be about right. The other thing that's worth calling out about 2021 is as we got into the second half of the year, we did see above average and above expected mortality. So, we'd unlocked, obviously, we had the Delta wave, and as we got right up to the Christmas period, we had, the start of Omicron. And then 2022, the most recent year, is on the next slide. So this is the line that's now in the sort of dark blue. And actually 2022 started very well. Death rates were comparable to 2019. Death counts were lower than we see in a typical winter. So Omicron was hitting us, but it wasn't hitting us as badly as a sort of average flu season, which is really interesting. But what's really interesting about 2022 is that although that first Omicron wave that coincided with a flu season was ballpark similar, the problem has been that we've had wave after wave after wave. And so death counts, which we'll talk about for now, but also death rates, they just failed to fall as we moved through the year, which meant that by the time we got to April, we started to see really quite significant excess deaths. Not the dramatic peaks of the first and second waves, but this chronic, constant problem of excess deaths week after week after week from April, May through the rest of 2022.
So is it fair to say that, in the first wave and the first peak and the second peak, it's very clear to see those excess deaths because they're just so huge? Yes. Whereas perhaps going forward and in 2022, we're seeing that this is kind of not a huge peak, but it's just a continual sort of excess death across the year. Is that sort of how it's gone from the first two waves to where we are now.
Yeah, I think that's right, Duncan. And without getting too technical about all this stuff, it does mean that the points about baseline become really, really important, because frankly, it didn't matter what baseline you used to understand how awful that spike was in 2020 and at the start of 2021. You can use any baseline you like and it's going to look terrible. Now that we're getting into this kind of chronic problem, it's really important to be quite precise about where deaths ought to have been, because otherwise, if you're out by 5%, you might double or the excess or make it appear to disappear entirely. So when you've got a sort of chronic continual problem rather than a short sharp spike, these technical points matter more. And we've already had a bit of a spoiler as to how 2023 has started, and it's not pretty. On the next slide, you can see just over on the left of the chart that 2023 has started with mortality which is almost as bad as the start of 2021. So very, very high death counts. Now, a lot of that is real, I'm sure. We'll talk about some of the acute factors that hit us in December later. You'll all obviously be aware of the flu, the very sharp cold. So some of it's real. The optimist in me is hoping that some of it is actually a registrations artifact, that there's a little bit more death registration delays in the system that have been registered in the first couple of weeks, and that hopefully on Tuesday we'll see a much smaller number. But I by no means could I guarantee that. That's really just...
It's very much worth looking at what happens on, as you say, Tuesday, to see whether that's just kind of Christmas delayed, in terms of reporting, or whether it's actually a real thing for 2023 in terms of this huge excess.
Absolutely, and I'll be reporting with this chart on Tuesday morning, shortly after 9:30, and then sharing the CMI's age standardized analysis in the afternoon. It takes them a couple of hours because they use the ONS data to do that. So on the next slide, then, how does this look age standardized? Well, actually, pretty similar. Same kind of patterns. This is the CMI output, so that you're familiar. You can see essentially that elevated mortality, the red line in 2022 coming through. You can also see those grey bars. So that gives you the kind of historic range that we were observing between 2011 and 2019 for context. And here, as I say, this is death rates. It's clearer actually if we move to the next slide. That gives you the progression of mortality rates between 2011 and 2019. Forgive me, I've truncated the y-axis so that you can see more clearly what's going on here. But there's a clear trend down. Now, you can argue about what type of line. I've just, for visual effect, put in a simple linear progression. Probably it should be log linear. But essentially, we've got decreasing mortality. 2019, it's fair to say, was better than trend. So it was a fair bit lower, but it's worth calling out. You can't see it on this annual plot, but the last 9 months of 2018 and the first 3 months of 2020 had very, very similar low death rates to 2019. So we actually had a 2-year period of solid, consistently low mortality, and it felt very much to actuaries like this was our new best practice. Because that's the way, it doesn't progress in a constant way year to year. You get fits and starts and jumps depending on flu seasons, but death rates do fall.
In theory, if the pandemic hadn't happened, then we should be at least as good as 2019 and going down with the age standardized mortality.
Yeah, so you could project that blue dashed line to show you that death rates ought to be going down. What the CMI does for their benchmark is based on the fact that the first 3 months of 2020 and the first 3 months of 2019 had nothing between them in terms of the low mortality that we observed. CMI has just been treating 2019 as a benchmark. It gets you away from this subjective progression. We do feel that in reality by 2023 we ought to have been seeing lower death rates than 2019, but we've used 2019 as a benchmark throughout the pandemic for assessing excess deaths. So of course you're going to want to see what does the pandemic look like. So if we move to the next slide, we'll add in the 3 completed pandemic years. So you can see just how far off trend they all are. 2020, of course, the most awful. Death rates way higher than could reasonably have been expected. Some improvement in 21, some further improvement in 2022, but significantly off trend. Death rates considerably worse than 2019, and as we've already said, they ought to have improved further. Let's have a look at how this translates into excess deaths then on the next slide. So the CMI are reporting around 160,000 excess deaths for the UK on this age standardized metric. Because this is allowing for the population change, it is slightly smaller than you'd get if you did an age standardized comparison just using death counts. So the ONS's metric. Some really interesting effects here. Some people will have heard about mortality displacement. So many of the people who died in those early COVID waves had long lives ahead of them, but quite a lot also would have died, in the months and years that followed. So after that first peak in the second quarter of 2020, we actually saw below average death rates in the third quarter. And then again, after that first, that second peak in the first quarter of 2021, again, death rates fell below average. This is mortality displacement. People that would have died in the second quarter died in the first quarter instead. But then you can see the constant problem that we've had in the second half of 2021, and then in the last 9 months of 2022, of these chronic continuous excess deaths mounting up. This is aggregate excess deaths. And this is why I'm saying that we're seeing these offsetting effects and mortality displacement. It is important to look below aggregate. So if we look on the next slide, this is from the latest CMI quarterly analysis. Now, this quarterly analysis predates the pandemic, and it's mostly used by actuaries. So the benchmark here is not to be used for judging pandemic excess. This is a 10-year average. It's including 2020. It's including 2021. So every age group ought to have mortality a long way below this benchmark. But you can actually see that although the oldest groups are experiencing mortality below the 10-year average, the younger groups, and particularly females, are experiencing death rates which are higher than a 10-year average that includes the 2 pandemic years. So we're really seeing quite pronounced relative excess mortality, and I'm stressing relative.
That's quite shocking, though, really, isn't it? That we're seeing that particularly in younger adults.
Yes, I would absolutely agree. I think it's worth stressing. Of course, most deaths and most excess deaths are happening in the oldest age groups because that's when most people die. But in relative terms, death rates ought to be very, very low for young adults, but the proportion of excess is highest for those groups. So it really feels like it's the young adults that are being most affected by the indirect impacts of the pandemic. And we can come on to talk about some of those. The next slide actually helps us drill a bit further into this. I've called it mortality by cause, but I'm actually I'm simplifying just into COVID and other at this point. And in the first 2 years of the pandemic, 2020 and to a large extent 2021, pretty much all of the excess deaths that we were seeing were driven by COVID, and directly by COVID. It was people dying of and or with COVID. Actually, that has started to shift now, and through 2022 and into this year, we are seeing more of the pandemic's indirect impacts starting to come to bear. Now, where you draw the line between direct and indirect impacts has some subjectivity, but what I'm talking about there is the sort of after effects of a COVID infection, so elevated cardiovascular risks, for example, after somebody has had COVID. I'm also talking about missed diagnoses. So you'll have seen the British Heart Foundation research showing around 500,000 people in the first wave stayed away from GPs, from medical care, and missed out on blood pressure diagnoses and so on. The build up of pressure within the NHS. Actually, if we go to the next slide, I've got some of these listed out, so you can kind of read while I talk. But we've all heard about the real demand pressures that are there in the NHS at the moment. So 999 calls taking longer to be answered, ambulances taking significantly longer to arrive, way outside of the 18-minute response time, and often over an hour for those category 2 emergencies, and huge waiting times in A&E. So that these are some of the chronic factors that have been building up through the year. And then across December, we've seen these acute factors as well. So we saw that terrible flu wave. We've seen COVID, a fifth wave of Omicron hit us, and also that very cold weather. Did anyone want to come in?
No, I just, oh, sorry, can I just say one thing? That, I mean, we've been going into this in quite some detail, but the reason we're going into it in detail is because people think deaths are easy to count, and they're not.
Yeah.
And it means that in the first 2 years of the pandemic, particularly the first year of the pandemic, almost all excess deaths were COVID. There wasn't really a complicated story to tell. Pretty much any way you would look at it, you'd see a big spike. 2022 is different.
Yes.
We've seen COVID deaths, a lot of COVID deaths, but we've also seen a lot of other deaths. And how you count and what you compare it to completely changes the conclusions people draw. So it's really open to misinformation. So the reason that we've been digging into it in this detail is to try and explain this is the gold standard for how you look at it. And when you look at it in a gold standard, you see really high numbers of excess deaths. We're seeing much higher mortality than we should do given historic trends. And we're seeing it in younger adults as well. And we're seeing a whole combination of different reasons causing that, some of which is COVID, but not all of it. Sorry.
No, it's a great summary.
Can I just follow up and ask, the younger adults who are dying, is it just a question of everybody's dying a bit more across all the different main causes of death, or are there any particular causes of death that are showing itself as the most prominent?
So most causes appear to be elevated. It's worth saying it's quite difficult to drill into this. So the best source of data that is publicly available is the OHID data that the Office for Health Improvement and Disparities that Duncan was talking about earlier. That's very useful data, but it only does one-way slicing. So it allows you to examine deaths by age. You'll see younger people with the largest relative excess, by place, and you'll see it's often deaths at home, although there's been a shift back to hospital, and by cause. And you'll see that many causes are elevated, apart from cancer and things like dementia. Cardiovascular is where a lot of it is, and a big part of the questions that we're asking at the moment about those deaths at home, for example, is how many of those are sort of okay, where people have decided with their clinician that the best thing for them is to stay at home with their families, and how many of them are problematic, an ambulance isn't getting there in time, and it's and actually looking at the cause is one way to do that. So if we're seeing a lot of young people dying at home with cardiovascular problems, then that is an issue. Now, three-way splits like that aren't in the public domain at the moment, but it's really interesting question to explore.
And I think you also have something about A&E as well. Is that right?
Yeah, so I did some work before Christmas to quantify that. Just one example to kind of close on is on the final slide. And so this is work I did. It built on work that John Murdoch did for the Financial Times in the summer, and the Royal College of Emergency Medicine did something very similar. They released it about a week or so later. And essentially this is looking at the impact of hospital delays. And we know from published research that for every 82 patients waiting 6 to 8 hours, there will be one extra death. For every 72 patients waiting 8 to 12 hours, there will be one extra death. Now, these are associated deaths. These aren't deaths that are happening within the A&E department. They might not even be happening in the hospital. But within 30 days of the delay, these deaths have been historically observed. And if we look at the waiting times that we've seen through this year, and particularly towards the end of the year, you can calculate, we would have been seeing around 500 additional deaths a week in December 2022, just arising from these very long delays. So that's against a sort of theoretical, idealized model where there were no 12-hour plus delays. But really quite extreme.
No, that's sorry.
Sorry, I thought Leonard's had his hand up.
Thanks, Stuart. That's really good data, actually. Just to place back to you, so I've got this, and the listeners got this too. Normally, you expect everyone's life expectancy to get better over time. Then COVID hit, and unfortunately, 160,000 people died. So that's the population of Oxford over the last few years. So that's crazy. I think we all agreed as a country we're going to focus on COVID to help the NHS and save lives. But what I think you're saying here is there's an elephant in the room at the moment. COVID has affected everything. And actually what you're saying now, this year and last year, you can't expect to live longer. I think you've actually gone a step further and said you can actually expect to live shorter lives before COVID. And that is shocking, because that's ultimately what we've been saying in Independence Age, why we've been harping on about stopping transmission, vaccination, concentrating on numbers. And Duncan's numbers are really showing everything here, why you've got to keep the eye on the ball, because clearly there is an elephant in the room. Have I got that right?
So I won't go off onto too much of a tangent about life expectancy. There's two different ways of measuring life expectancy. There's something called period life expectancy, which is what's going on right now. And there's cohort life expectancy, which uses assumptions about what will happen in the future to project and predict how long people will live. So strictly, period life expectancy, what's going on right now, has fallen. But we would expect it to bounce back. It's already gone up again for between 2020 and 21 and 22, but it's in a worse place than it was pre-pandemic. Cohort life expectancy has also fallen, but cohort life expectancy is saying we still do expect, actuaries still do expect life expectancy to go up once we get beyond the pandemic. Period life expectancy will keep rising, but we now expect it will rise more slowly than we felt pre-pandemic. So we think there will be a long-term scar on people's life expectancies from this pandemic and from the direct consequences and the indirect consequences where COVID forced us to take actions to save lives, which unfortunately have consequences as well. There were no easy answers in this
I'll push you to the next step. And if we continue to do nothing, what is the consequence?
Well, you can see that the pressures that have been building through the NHS system, although COVID itself, the Omicron wave, is not directly killing people in anything like the numbers, because we've fortunately got good levels of immunity now that's been acquired through vaccinations and also, unfortunately, through infections. So we're not getting as many direct COVID deaths, but it is contributing to these constant demand pressures. It's meaning that NHS staff are home sick when they should be treating people. It's going to lead to ongoing excess mortality compared to where we would have been pre-pandemic. That's a simple fact.
Thanks very, very much, Stuart, to you and the actuaries in your group and around the world who are looking at this, because you've been doing this for nearly 3 years, as have we. And I suppose that the sort of final question is, when do you expect actuaries to stop looking at COVID?
To stop? We set up the CMI, the Continuous Mortality Investigation, after a previous pandemic.
When was that?
Coming up. Well, there's a bit of debate about whether it was started in 1923 or 1924. So whether this year is our 100th anniversary or next. But certainly it will keep going. The CMI has been there for a long time. I'm hoping the actuaries response group won't be around in 6 years, but in 6 years, I'm hoping to hand over the keys to the CMI to my successor and let them take it forward. But when will we stop studying the COVID pandemic? I remember reading a few years ago a paper published in 2006, and that paper was called "Is the 1918-19 Flu Pandemic Finally Over?" And essentially what was being recognized and acknowledged, and the theory that the author was putting forward, is that the generation of people who were young adults, actually, when the 1918-19 flu pandemic hit, tragically, had a long, decades-long elevated risks from cardiovascular causes, which stayed with them for the rest of their lives. So it's only now, nearly 100 years later, that generation are all no longer with us, and we can say that the flu pandemic's behind us. I'm expecting actuaries to be worrying about the long-term impacts of COVID for many decades.
That's fascinating. Thank you very much, Stuart. And I'll pass you back to Anthony for questions.
We've overshot by a long time because we've only got 10 minutes left for public questions, and 2 of them are to you, Stuart. So I'm going to kick off with those. The first one is from Robin Montaigne to be read out, and it says, I thought the use by your Australian colleagues, because somebody's obviously reading about your work, of a qualitative scale to rate the likely contribution of potential factors to excess deaths from negligible, like vaccine-related, through low and moderate to high, could be color-coded, I guess, to sort of post-COVID was interesting. Is it possible to apply something like that to the UK picture, and whether international comparisons can help with this kind of analysis?
Yeah, that's a great question, and I'm really glad to hear that people have been reading the work of my Australian colleagues. Yes, I guess I won't rattle through now and try and do it sort of on the fly. Not least because actually the contribution has changed so dramatically between the different factors over the last 3 years, and I'm sure will continue to. Maybe that's a good piece for the UK actuaries to do, is to take a look at 2022 and try to ascribe, which are the most material out of these factors. Although, as was discussed earlier, attributing between different drivers of excess death are really hard. If we're seeing more people dying because of NHS delays now, if you dig a little deeper, it's constant Omicron waves that are really contributing to a lot of those pressures. So how you ascribe them is quite hard, but it's worth looking at.
And one final question from Anthony Costello. I'm going to ask you, do you measure age standardized sickness rates? In other words, sickness that takes you out of the workforce? Because if you drop out of employment, it seems lots of people have, you have a much tighter labor market, and that is inflationary. And chronic inflation will lead to economic damage, and that in turns will lead to pressures on the health service and to other sickness. So if you do, all I want to know, yes, no, really, is if you measure those kinds of age standardized sickness rates, maybe we could do another session on that.
So the CMI, the same techniques can be used and are used, and the CMI does have that. We focus on insurance data. We haven't got as much available on public data, but want to explore offline and see if there's anything there that's of use.
Lovely, thank you very much. I'm going to move on. I've got another question here from Anne Jessamine to be read out. Does the panel know if there'll be any trials of nasal vaccines in the UK, similar to those being carried out in Canada? Surely the way to cut prevalence and associated health effects, including excess deaths, is to find a vaccine that stops transmission. Why has the ambition and investment to find a solution disappeared in the UK? Anyone on that? Danny or Steve?
I can say a few words. Yeah, I do think we're a little bit stalled, if that's the right word, in the UK. That's not true around the world. There are various ongoing trials. I'm seeing some really quite interesting studies on aerosolized boosters coming out of China. So I think the future is looking quite interesting. But I agree, not a lot of activity locally. But I guess we all will get to benefit.
Steve, you're muted. Yeah.
Just to follow on from Danny, yeah, absolutely. There are some really good studies, but the problem is that as well at the moment is that our target is the same, and that target continues to move, and that that target is the spike S1 region. And if we don't get a lid on viral diversity, then we're not going to, even if it's a nasal vaccine and you get the wrong antigen, it's still not going to work very well.
And why is the UK pulled out of it? I thought we were going to be the biotech leaders in the world and come up with all kinds of vaccines. Yet Kate Bingham was moaning at the Health or Science Select Committee recently, saying the whole thing's collapsed. What's going on? Anyone?
It's expensive.
Yeah, but you make money, don't you? I mean, you know, if you're going to have an industry, you've got to support it. Anyway, all right, we'll go on to the next question. A very good one from an anonymous. Is a person who developed pulmonary embolism, that's a clot that goes to your lungs, usually starting from a deep vein thrombosis in your legs, and can kill you or can cause serious lung damage. Is a person who developed pulmonary embolism following a previous COVID infection likely to have similar after a second infection? And that's an interesting question. I actually looked this up a bit before we came on because I didn't know. We know that from autopsy studies early on that lots of people who died had clots all over their body. We know that COVID is very much a clotting disease. We know that in sick people on ITUs, very high rates, 10 to 40% of those people will have some kind of clotting in their lungs. Non-ICU patients, it's lower, but it could be as high as 1 in 5 or as low as 1 in 30. And in mild cases, there's not so much evidence. But I'll just refer you to one big study, which we have talked about before, which is the study published in Nature Medicine 2 months ago, which basically showed the more times you're infected with COVID, the higher your risk for severe symptoms, hospitalizations, and death. And in fact, they found twice the risk of death after repeat infections, 3 times the risk of hospitalization, and 2 to 3 times the risk of clotting problems or embolism. And that would mean about 30 per 1,000 additional cases after reinfection. And vaccination doesn't make much difference. So actually, this could be contributing in some way to the excess deaths. But anyone else on that subject? Yeah, Leonard.
A difficult one, actually, but you can get clots for many reasons. COVID is one of them, but you can also get clots when you fly too. I think if you keep getting clots, then there's clearly a problem. There might be an underlying defect, so you might need to go to a doctor. But I think the most important thing is keep chatting to your doctor about this, because we've all got one, if you can find them. Yeah, COVID does put your risk of clots up, definitely, but there are other causes too.
There are some trials or anecdotal stuff, and I believe there are trials going on to show that sort of anti-clotting medications could have an impact on long COVID. Does anyone have a view or thought about that? Or does anyone know of trials going on?
Just to say that, sorry.
Go on.
Yeah, Trish.
No,
Yeah.
go on, Danny. You'll know more about it than me. I was just going to say there are trials going on, but I'm working with frontline long COVID clinics, and nobody is actually treating long COVID without anticoagulants at the moment because they're waiting for the results of trials. So this is wide open right now. The jury's still out. But I'll hand back to Danny, who'll tell us about the research.
Well, no, just to add one sentence to that yes, people are waiting for the RCTs, and it's one of the arms of Stimulate ICP, which is the NIHR-funded trial at University College, and we'll wait to hear about it.
Oh, well, we'll report that back as soon as possible. I'm going to, one more question, which I think will raise all your hackles. It's from Claire Nuken. Sometime in early to mid-January, government policy changed so that adults less than 50 years old at the moment will no longer be offered a booster and will not be eligible for a booster when they reach 50. As a mid-40-year-old, I am concerned that this will mean I'm not as well protected against getting seriously ill as the over 50s. I work full-time, so surely the government would want me to be able to continue to work if I caught COVID, but didn't get seriously ill. What does the panel think about this policy change? And she goes on, in addition, all vaccinations for children were dropped some time ago. So parents no longer have a choice. No boosters are being offered at all. I'm concerned again that the health and well-being of our children is not a priority for the government. Again, what does the panel think about this policy change? So all raise your hands. I'm sure you've all got views on this. Who wants to go first? Christina?
Sure. I think the children's stuff is crazy. Children definitely benefit from vaccination. There was just another big paper that came out yesterday showing that the vaccine in 5 to 11-year-olds is very, very safe and very effective. I don't understand the rationale for not allowing people who are becoming over 50 to get the booster. I'm in my 40s. I would like to have access to it. I'd like to have access to it now. It's basically saying that people are kind of stuck at their last dose, which is for many people over a year ago now. And we know that it wanes. And although protection against severe illness lasts longer than protection against infection, it doesn't last forever and it does wane. So I think there is definitely a case for allowing people to access it. But JCVI obviously disagree.
Yeah, I'm approaching 50 as well, but from the wrong direction. So anyway, anyone else on this about government policy? Danny?
Yeah, no, just to pull together all the obvious things that we say around this table every week, that we're still in a period of, relatively high prevalence. So, low compared to where we've been, high compared to where we expected to be. We're still in a period of excess deaths. If you look at all the data, every few weeks in New England Journal of Medicine, those excess deaths are massively skewed to people who haven't been boosted and don't have recent immunity on board. So although we all feel a lot safer than we did, we're all at risk of featuring in those stats or infecting somebody vulnerable next to us on the bus who's going to feature in those stats. So why would you not want to keep up your booster campaign?
Well, is it financial? Do you think it's because it's going to cost quite a lot of money? Oh, we've got 2 more hands up. I'll take this. Leonard and then Steve.
I guess it falls into the narrative that COVID is just like the flu. There is no elephant in the room at the moment. We can just treat it like a flu. So it may not be cost, but actually that's quite a big decision that someone's made, and it's quite brave, I would say.
Yeah, because the costs of being unemployed and sickness and the inflationary effects, as I've said, could actually be very, very big in the longer term. But anyway, Steve, you had something, you're muted.
Yeah, sorry, I'm actually just quickly to pick up on Leonard's point, just the flu is something that's very commonly bounded around. And I think the graphs we saw today show that just the flu really isn't just the flu. Many of these diseases can lay you low. They have an annual cost in terms of mortality and morbidity, but we've kind of grown to accept that because it's what we consider to be normal. And it's very clear that the 5 waves of COVID that we have this last year is not normal. The flu peak we just had is not normal. We need to do more. We need to be vaccinating more for all of these sorts of diseases where we have a vaccine. And of course, what the strategy is ignoring as well is long COVID. And that across the board is going to be a long-term problem. And if the vaccine is one of the few things that actually reduce the incidence of this terrible illness, so why on earth wouldn't you do it?
Susan Mickey.
Yeah, hi. I just want to really emphasize that we want a vaccine plus approach. So yes, we want the vaccines, but we mustn't forget the plus. The plus is all those things, again, we talk about each week that we could be doing to get the transmission down. If we get the transmission down, we get infections down, we get long COVID down, we get excess deaths down. And these can be quite small things, as we've said so many times. But I think the key things for people to really focus on is indoor air, making sure there's ventilation or filtration, that you avoid risky situations. If you have to be indoors when there's not sufficient ventilation and or air filtration, wear masks, meet outside where you can, etc., etc. So I really think we need to remember that, not only because it helps to, help in addition to the vaccine, but also, as Steve Griffin was saying earlier, it helps to prevent the virus evolving in a way that's likely to escape the vaccines that are being developed anyway. So it's a kind of win-win that we go down this road.
No, absolutely. And just on the children, just to finish on the children's question, United States, Canada, and 29 European nations all vaccinate children over the age of 5. And the only two countries in that group that don't are the UK and Sweden. So I do think we are outliers, and I think more pressure needs to be applied on our government. That's all we have time for today. A huge thank you to Stuart. We must get you back to discuss other, because that data was really fascinating, a brilliant presentation. Thanks to Duncan, of course, for the data, and to all members of the public for all the questions that you send in, and of course to our panel members. We will be back next week, same time, same place. Till then, keep safe. Bye.
Bye.